Welcome everyone to this first set of webinar series co-organized by the working group on global surgery from the World Medical Association Junior Doctors Network, as well as with Incision. It's a great pleasure also to start this collaboration because we are both youth health organizations which are really focused on global surgeries, a topic that is really close to us. Today we will have the honor to have a really expert keynote speaker that I will let my colleagues to present, but I just wanted also to use this space while we finalize the logistics to let everyone know that we're really inspired by the work from our members and that we're really looking forward for more collaboration opportunities that there will happen in between the Junior Doctors Network working group as well as with Incision. Without further ado, I'll also like to introduce the co-chairs from the working group on global surgery from the JDN. That is Dr. Preeti Sawant and also Dr. Ramita. So if each one of you, or I'll hand over now to Preeti also for the next point of the agenda.
Hello, everyone. I'm Dr. Preeti. So this is the very first inaugural session of the Global Surgery webinar series, which is a monthly event that we are planning with global leaders in the global surgery field. We have Dr. Isha and Dr. Carolina from the Incision team, and also Dr. Ramita, my co-chair. So without further ado, I'll hand over to them so we can proceed with the session. I hope you have a great time knowing about global surgery fundamentals and come up with interesting questions at the end of it. So Dr. Isha, Dr. Carolina, please proceed. Thank you.
I'll take next. I'm the co-chair of the Global Surgery Working Group, and I'm happy to be here today. So I'm hoping to learn a lot from Dr. Lakhoo, and I've been a big fan of her work, and hoping to make this a very interactive conversation. And also, if you have any questions regarding the project, please, regarding the presentation, please don't hesitate to send it as questions in a direct chat to me or Dr. Preeti. Handing over to Incision. Thank you.
Hello, everyone. It's an honor to be with all of you here for this inaugural lecture between the Junior Doctor Network and Incision. I'm Carolina Ramirez. I'm the Director of Advocacy for Incision, although I do want to correct, I'm not a doctor yet. In a couple of years, but not yet. But it's an honor to be here with everyone, as I mentioned, to begin the series. So without further ado, we can start with the introduction of our keynote speaker. Is that all right with everyone? Yeah, perfect. So Professor Lakhoo is a leading global figure in pediatric surgery with a distinguished career dedicated to advancing surgical care for children worldwide. Now a professor of global pediatric surgery with the Oxford University Global Surgery Group, Dr. Lakhoo first started her training in South Africa, which then further specialized in a fellowship in a Great Ormond Street Children's Hospital here in the UK. She brings extensive clinical and academical expertise to her work and to her contributions within surgery with more than 300 publications. She is the president of the Global Initiative for Children's Surgery, GICS, a global platform that emerged from the Lancet Commission to improve surgical systems for children in low and middle income countries. Furthermore, as chair for the International Forum for the British Association of Pediatric Surgeons, Professor Lakhoo actively fosters global collaboration, including capacity building partnerships. So without further ado, Professor, I will hand it over to you.
Okay. Thank you very much for inviting me. It's always a pleasure to speak to the future, that we start something, and it's always good to see young people using this as a baseline, but even doing better. There's a good saying that when your successor exceeds you, then you've done a great successful succession planning. So I'm looking forward to seeing all of you develop and through some mentorship from senior people, take this forward and not allow it to die. Two apologies. One is that I need to go to theatre as soon as we finish this presentation. So I'm dressed in theatre garb and not in formal clothes that I intended to. And secondly, the technology is not helping me. It keeps going onto the screen, which freezes. So I'm just going to leave it at this phase so that we can actually have a presentation, if that's okay. So I thought I put these slides together, and I have given a similar talk about a month ago in Edinburgh, just to highlight that most of the time you are training in your careers as medical students or as specialists or at the beginning of your careers, and you have your career that you need to establish before you feel you become independent and useful in the global sense. But you can be useful from this level as well. And therefore, I put this to you, that how can I get involved? It's a question I get asked all the time, that I'm a medical student. How can I get involved? I've still got medical school to go through. And I thought the best way to show you that is to explain what global health is, and then go through some of the examples of people that have asked me this question and joined me and have made success of what they started. And I always say, when you start something in global surgery, it's a lifelong mission. It's not something that you do today and forget. So it's frozen. I'm trying to get. Okay, it's working now. So what is global surgery or global health? The concept is like flown around that you are here to help others in LMICs because we have everything. That's very patronizing. There's a lot to learn from each other. So you always look at global surgery as a collaboration between where you are and other areas where you can learn from each other. And one day where health equity is achieved. Teaching abroad, we are not always the good teachers. Teaching comes from the other end as well. There's concepts of doing missions, like forming a group from high-income countries, going to low-income countries, doing things and leaving. And that is not actually helpful, because it's like giving the fish and not the rod. So you just go there, you do your thing and you leave, but you don't know whether that is what people need. Surgical operating teams, I think if invited and done properly, the missions are good as well, but as long as they are done properly, where you start off by invitation, where you get invited to help with a certain kind of procedure. So you go there and your training is learning what is out there and what can you do which is feasible, and also looking at the entire team of surgeons, anesthetists, and nurses of how this is feasible in this environment and how can we make it happen. We are not givers and recipients. We are all in it to make sure that there's health equity in the world. And I think earlier concepts, I mean, global surgery has been in people's blood that come from low-income countries. It's become very fashionable in high-income countries and become very sexy, if I can use that term. But if I look at my upbringing, I don't come from a very wealthy background. And we always took part in community health groups. We used to do first aid classes and learn from each other. My grandmother was a self-taught and supported by a GP as a health visitor, because people couldn't afford to go to doctors. And also, if you lived in South Africa, there were huge racial laws during my upbringing. So you couldn't go to any hospital or any doctor. It has to be somebody that is of color. So also, when we were at medical school, we used to run clinics for the community where we lived in. As junior doctors, we used to run clinics in the informal sector close by. So this has been something I've been doing from childhood. So it's not something new. It's just become very new in the Western world, because I think it's a way of, I'm going to present Dr. Emmanuel Makassa's quote, and I think that will be very appropriate for you to understand what I'm saying now. So what is global surgery or global health? And a very succinct definition was given by one of our HIC colleagues, who said that it's a multidisciplinary involvement. And yes, it is. And it is an involvement in both areas. And it's succinctly put, if you do it correctly by collaborating and sharing ideas rather than doing this MDT in the high-end, high-income countries and not engaging or involving the low and middle-income countries where work is going to be done because they know the arena, we don't know. So it's a good definition as long as it's done properly. But look at the view from LMICs, because now all the low and middle income countries are bombarded by high income country universities to want to do global work. And Emmanuel Makasa is a trained orthopedic surgeon, but spent time as the international global surgeon at the WHO. He's originally from Zambia, and he's actually very upset at the way global surgery is being turned into, research, publications, data mining. And I like to use this word mining because historically, low-income countries were mined for their gold and diamonds and copper and now for coltan. And this is now data has become very valuable. And he's saying, global health should not be about research, publication, data mining. Our people also want service delivery. And then neither should it be about using our unfortunate situation to raise money for yourself and your programs in the Western world. And just keep this in mind that you might think that this is the right thing you're doing and you're doing all this good and you're going out there and you're helping people. But you need to understand how it's been viewed, because the playing field is not here. The playing field is out there. And because the playing field is out there, you need to follow the rules that happen out there and learn from the people what the need is rather than what you think is a good idea. This is another sins or 7 factors that you need to keep in your mind when you're doing humanitarian medicine, as it was called before. But a lot of the time they were, historically people going there and saying, okay, we're going to do all this complex bladder operation and then do the operation on 10 patients and leave. And the institution doesn't even have a high care setting to look after these complex operated patients. So you're just leaving a mess behind. You think that this is a technology that's going to be useful there. So, a mismatch of technology that you take there is disastrous because it's people's lives at stake. Failing to work with other bodies that are there. It's very important that when you're involved, that you're not all working in silos and trying to do the same thing. And what is actually happening now is NGOs and universities are competing. And they're competing for space in the low and middle income countries, which is extremely, extremely disturbing. That's not what global health is all about. Follow-up plans are not done if you just go and leave. And then, negotiating with the politicians to push your agenda onto the people where that agenda is totally inappropriate because people on the ground know what the need is. Also saying to a country to say, look, you guys need laparoscopic surgery, so I want to come there and show you because you really don't know what you're doing. I mean, that's not how it should be. You need, and also you think you're doing the right thing, but it is not what they need. So a bit like, what happened during Ebola, that people in Africa or low-income countries understand community health. They know what it is. They know what's public health, and they work really well. And most of the parts of Africa had prevented Ebola, or prevented COVID, or kept the people safe because they knew what isolation is about. They knew what distance is about. We don't know in the high-income countries. We have no idea. And if you analyze what happened during COVID, there are huge successes from LMICs that nobody talks about because it's LMICs. A high-income country does one good deed and it becomes a big, big, big show. But we were actually not good in what we did during Ebola, where communities, where you're dressed in this suits and force communities to come into tents, they know how to isolate themselves. So, you think you're doing the right thing and you just might not help. In fact, you cause more damage. So when I talk about health, my vision is one day around the world there will be healthcare that is equal in every sector. There might be some razzmatazz in the UK where you can get a polished room or hoteling like facilities, but the actual medical treatment you give is the same in Tanzania or in Bangladesh or in Oxford or in New York. It's the same technique and the same healthcare that you provide, but you might be in a different kind of hoteling, I can call it. So when you talk about having this vision, and if we start now, we will achieve it. But if we don't start now, we will never achieve it. So when you talk about equality, equality means like giving everybody the same. And equality doesn't work because some people start at a very low level and some people are already halfway there. So in equity, you support provided to achieve the goal. So you give the person that has the least more support and the person who has enough, no support. So that will bring about equity so that the barriers can be removed and we can, there will be no need for accommodation or support because we are all on a level playing field. What are the challenges? So, you are going to be clinicians, you are medical students, you have busy clinical service. If you are in a surgical specialty, it's a skill-based specialty, so you need to keep up your operative skills. It's difficult to get protected time for research. If you take on a surgeon scientist role, then you fall back on your clinical acumen. Funding is an issue, time management is an issue. So these are all things that go through our minds that as you're developing your career, do you want to be a surgeon scientist? Do you want to be an academic? Do you want to go into pure academics and in the laboratory kind of field, such as pathology or microbiology, which you can do clinically or academic or from an academic point of view, or have a split career between academia and clinical work? But when you are training, how do you manage all these things? So personally, I'm a full-time NHS paid surgeon, and all the global work I do is voluntary. So the university doesn't pay me, but I give them a lot of kudos for the work I do. And the reason for that is that whatever research I do is important to me, important to what I want to do, because it makes an impact. And no head of department can tell me what to do because they don't pay me. And I feel this is a good place to be in because you don't have a boss deciding what money you should bring in and what papers you should write and what research you should do. I think what I do is voluntary, appropriate, because I believe in it. So how can I get involved? So as medical students or junior doctors, you can take, you can do global PhD. So I run a PhD program. You can do a global surgery MSc. So PhD means 3 years out of your clinical work, and also it's expensive. MSc is 1 year out of your clinical work or 2 years out of your clinical work. And it's also expensive because it's a program with courses and so forth. In Oxford, we run something called the MRes, and that is very popular amongst a lot of young people like yourselves, where you take a year out and it's purely research-based, and it's run. So we run it in a way that I meet all my students once a week, and we do projects which I'll give some examples for. You could assist in systematic reviews. You could form a partnership with somebody from the low-income countries. And that is quite a nice way of doing it, where, say, you have contacts or networks in low-income countries, then equal as an intern or a junior doctor, you form a partner with a junior doctor there, and then grow together like as your careers develop. So from medical school days to junior doctor's day to SPR days to then consultant days, where you start working on things together. Like your partner may say that, look, we really struggle with appendectomies, or we really struggle with antibiotics. And then you can support because you have easy access to papers. The person that has easy access to patient kind of laboratory work or kind of, blood samples that they have analyzed or sputum that they have analyzed or whatever. And you work together where you equally contributing to this development of, like, say you want to work in a community to pick up tuberculosis, so you do sputum samples, and you from the high income country can support with publications or analyzing things, not analyzing the sample, but maybe looking at some statistics or so, and the person out there has the laboratory skills to test for TB in this particular community. It's just an example. Another way of getting involved is there's an organization called GASOC, and they are a trainee group similar to Incision. And when I speak to people that are not Incision, I tell them, join Incision. It's a very good organization. And then, you have academic foundation programs, you have academic CT programs. So you can join that. And your academic side, you can do with us in global surgery or with whichever institution you're working in, work with their global surgery team. So I'll start off by giving some examples. So Sian was a AFP, Academic Foundation trainee, who came to me wanting to do some work in Kenya because he's got a family who live in Kenya, and I think his parents are Kenyan. And he felt he wanted to do something in Kenya for his academic part of his AFP. So he was given 3 months and then the rest. So I think the Academic Foundation program works like that, that some people get 1 day a week to do the research. Some people get 2 weeks at the end of a term. Some get 3 months in a bulk. Some get 1 month and 1 month at a time. So Kian's was 3 months in one block. So I had a group of people in Kenya that were there for a long time, and there was a Mike English's group that was working with pediatricians in one sector. So I approached him and said, look, what we'd like to look at is there anything that we can network with? And he wasn't so sure. So we went with the idea that if we know how many children are being operated on in district general hospitals of the group, then it will be helpful to know what facilities they need or where the gaps are. So we talked about it just as an idea, but not to implement it. And immediately the group from Kenya came back to us and said, no, we don't want to look at surgical input. We are really stuck with neonatal pain. So with Kian, we worked with the group and we designed, we did a systematic review, we designed guidelines, which the Ministry of Health then accepted. So in that 3 months, we did all of this, and we reduced the cost of neonatal pain management by 65% by having a guideline that we established with them, with our group in Kenya. And Kian then went off to work on pain relief for the NHS England, which was then existing, and then NHS England wanted to look at antibiotics resistance, so Kian got a job with them. So his work is becoming very global. Another story, Somi's story. So Somi was a medical student also. So she wasn't a junior doctor yet. She's a medical student in Oxford, and we were at a meeting and we were talking about blood transfusion. And my colleague from Bangladesh said that they're really concerned about blood transfusion in Bangladesh because people have to buy blood. And so families, if you need to do an operation, the entire family has to travel with the patient, no matter where they come from. So you find a person from a very rural area, say as far away as Southampton, coming here, but the entire family has to come because if the child needs an operation and needs blood, especially for major operations, then they bleed the family. But the hospitals in Bangladesh are also very good, where every staff member has their blood group tested, so that if a child needs an operation and there's no blood that the family can afford, doctors, anesthetists, nurses, anybody, cleaning staff, they bleed themselves for these patients. So, when I talk about community spirit in low-income countries, this is what I'm talking about. The people are there to help. It's not about, I might need this blood. It's all about helping each other. So Somi's story is basically, we then, together with our colleagues in Bangladesh, we matched Somi. So we matched a medical student from here to a medical student there. I had my research student match my research student to a newly qualified person who wanted to do research, so became the research student. We matched a trainee from my SPR from Oxford to a trainee from Bangladesh. And I worked with my counterpart, who's the senior surgeon in Bangladesh. And we worked together whereby we identified that the hemoglobin level, the normal hemoglobin level in children out there is 6, not 7 and 8. Like here, you got to transfuse if the hemoglobin is less than 8. But there, people run around with hemoglobin of 6. We then worked out how much of blood was needed. And a lot of the times, there are no blood tests are done, but doctors assess, just clinically assess, whether blood transfusion is needed or not. And then we realized that that practice was not pretty accurate. I mean, they were doing okay, but there was a lot of blood also being wasted. So we bought them hemoglobinometers, and hemoglobinometers were used. And the impact of that was the cost saving for $3 million USD, no wastage of blood transfusion. And the country is now, the organization of that hospital is working much better because of the stories. And Somi and Sarah from my team are working with them with other projects. So I said to them, this is your lifelong project. So they're working on other projects now with the same team and kind of building themselves up with Somi and her counterpart, Sarah and her counterpart, Tamina, my colleague, and myself, just growing together in this field. So the other thing I did was a lot of Oxford students, but most medical students go out for electives, and many go to low-income countries. So I realized that they were coming to me to say, oh, can you help us find a contact? We'd like to go to Africa. Is there anybody where in Africa you can go? And I said, yes, we can, but let's structure this, that all of you from this year, so for that year, there were 8 of them. If you're going for elective, found your counterpart in that hospital. I can give you some context which hospitals you can go to, and then liaise with myself and a senior surgeon out there or a senior pediatrician out there. And what we did is we used medical students with their counterparts there, and I gave them a topic. So the first topic I gave them was a kidney tumor, which is common around the world, high-income country or low and middle-income countries. So they worked on the theme to look at what was the outcome of Wilms tumor, kidney tumors in whichever hospital they went, and the Oxford figures. So the whole concept was a novel idea, and the 2 students who presented it, the team, the actual Oxplore concept won the prize for this concept. And every topic that they've chosen, so the first one I gave them was the oncology one, on Wilms tumors. The second one I gave them was about an organization that had a kind of a safety checkbook to see if the checkbook was working or not. And then the low-income country medical students are saying, no, we will decide now which topics we want to do. So let's just Oxplore explode, and Oxplore is exploding with this going on year in and year out. And you can see our low-income country people talking about it. And there's been 5 publications or 5 themes that they've studied on, and all 5 have been prize winners. So there's determination, there's will, if you can work together and see how it can make a change. Let me tell you about just a recent story of a medical student. So I'm sure those of you who are medical students, you have a SST program, special study module. So in Oxford, we initially had about 5, but now we have 25 coming for special surgical module to global surgery. And so Amy was a global surgery SST. And we then, for the SST, we organized a journal club with the international students like Incision. At that time, Incision wasn't existing. So we kind of chose Incision or a group of that I knew from Kenya, from South Africa, from South America, Brazil. So we had like kind of 7 different countries representative at this journal club. And that's where Amy met Wangari. So Wangari is from Kenya and Amy is from Oxford, and they decided they wanted to do some study, like a systematic review. So they were talking to each other for a while, and then this is what Amy and Wangari said, that they were participating in the global surgery spatial study theme, and they wanted to do a systematic review. They came for advice. I supervised them, I mentored them, and said, okay, let's do a systematic review on appendicitis, which is common in both countries. And in fact, the idea of appendicitis came from Wangari. And then so they went off trying to do this, supported them, but we suddenly realized that Amy could get everything because systematic review is designed by high-income country groups and not low and middle-income countries. And Wangari couldn't find a single paper. So she was stuck, and it just didn't work. So I said to them that, this is what was happening, that they could do the protocol, but Wangari was getting more and more frustrated because according to the systematic review rules and regulations, it didn't account for low and middle income countries. So it's a very high income country concept, which is sold. And many years ago, when you have this randomized control trial was fashionable, right? Randomized control trial was only doable in high-income countries. It was really difficult to do in low and middle-income countries. So they were really upset, and they were really angry that they realized that the whole systematic review was not helping our LMIC colleagues, and you couldn't really work together. So I said to them, okay, why don't you write an article in one of the medical student and junior doctor journals to highlight how inappropriate systematic reviews are, because it hasn't taken into account the low-income countries. But they even did better. They've created a model for equitable and ethical global research in the context of systematic review. So the publication is being accepted by BMJ, and wait for it to come out. It's really lovely the way they've written it. I mean, the first writing was full of anger. So I took all the anger out, and it is really beautiful the way they've put it across. So that's another way of understanding that things are not equal. Things are not the same. I'll give you another story, and I thought through the stories you can understand how you can get involved. So Bip was a trainee with me, and he wanted to come with me to Tanzania because I have my, now it's 28-year collaboration with Tanzania. And I said to him, look, Bip, you can't just come, you have to be invited. So let me ask my collaborator out there as to what do they need you for and how you can be helpful. And they came back and they said that the medical officers, which are clinical officers, they're not doctors, a little bit like physician's assistants here, but they're a bit more sharper than that, that they are not being upgraded, and they are not being supervised, and usually they don't get refresher courses. So if he could run refresher courses for medical students, junior doctors and medical officers mainly on resuscitation, and when they come to A&E, how to resuscitate a baby or a child or an adult as the first liner. And I thought that was a really good idea, and that came from Tanzania. So Bip then came and accompanied me, and he formed a partnership with a Tanzanian trainee, and together they designed it, and in 2 weeks they ran a fantastic training program. They also compared, at the same time, they compared high-income country and low-income countries' outcomes on birth defects. And it was such a kind of signature paper that Naomi Wright, who's done a lot of work or good work on birth defects, used that as a template. So it was already templated when she took the idea and started in Tanzania with the work, and she subsequently did a PhD. So that has become like a signature paper that Bip did with his counterpart, because it was their ideas together. when he finished his CCT, he just felt he really didn't want to work in the NHS. So I had a colleague in Blantyre who was funded by California group. No, they were not funded. They were funded by the Dutch group, and the Dutch pulled out. So I said to him, look, Eric is really struggling. The Dutch funding is gone. There were 3 Dutch surgeons that were there 6 months at a time, supporting and developing children's surgery. So we got some funding for it from the California group, and he went out there, and he's never come back. So during his time, there was another trainee with me, and both of them have remained in Malawi. And what Bip has then done is that he's then moved from where 4 or 5 surgeons were over 5 years, and then moved to another city and started pediatric surgery from the start. And over 10 years, he's built up a unit with the 3 consultants now. He's still funded by German and Texas funding, but he's done similar to what I've done in Tanzania. And at the moment, he's reaching the point where he's handing over the mantle to the most senior consultant to then independently run children's surgery in Lilongwe. So how do you develop research in low-income countries? So firstly, I was invited about 28 years ago to come and develop pediatric surgery in Tanzania when there was no pediatric surgery. And how do you do that as a, I had full-time NHS job. I had 2 children under 5 years of age. And my husband said to me that, look, I think you should go. They've invited you. They want you to do something. It might be feasible. So I went on a fact-finding mission on my own. My husband took time off and looked after the children. And what I found was that they were very able surgeons, but they were not trained pediatric surgeons, but very able surgeons doing children's surgery, but nothing complex. And there were pediatricians with a ward full of patients that needed surgery. And all the children that were operated on ended up in the adult ward with 60-year-olds and 70-year-olds with, legs in traction and so forth, and this baby with interception next door. So just talking to the surgeons, and I knew that they are able, talking to the pediatricians, and I realized that they had 4 wards. They had Ward 1, Ward 2, Ward 3, and in the 4th ward, they have mothers sleeping there who were looking after the children. And I said to them, I got the surgeons and the pediatricians together, and I said, why don't we convert this ward into a pediatric surgical ward where children that are needing surgery, you put them in this ward, and surgeons come assess them with you and then operate, and they come back so that there's pediatrician support for post-op care. And the matron who was doing a ward round with us said, yes, I'll do it. It just took the drive from the matron to develop this ward, and pediatric surgery was born in Tanzania. And over the years, I've been going there for 2 weeks at a time per year in my annual leave with my own funding, and just working with my adult colleagues and showing them some of the nuances for children's surgery so that patients don't have to be flown out to India or South Africa for complex surgery. So the first 10 years of my work involved converting adult surgeons into pediatric surgery. So we had about 10 surgeons qualified, and now Tanzania has its own training program for surgeons and has joined the COSEXA group for training surgeons in the country, and they're training surgeons from around the neighborhood countries, like from Congo, from Burundi, from Rwanda. They're training up surgeons. So from no pediatric surgeons, they now have 37, of which 7 are specialist surgeons in orthopedics, in neurosurgery, in plastics, and they're training up ENT surgeons now. So we've, how do you develop? This was clinical capacity building. And how do you develop research capacity building? And they have the same problem of busy clinicians, no support for time, no money, no time ring fence for research. So what I did is one day while I was there in the theater, there was this public health doctor who came he was collecting all the data from the computer. And I said, Godfrey, what are you doing? He says, I'm collecting data so that to do the hospital report, because it's part of the public health remit for them to write the hospital reports. And after talking to him, I said, would you be interested to work with the surgeons in pediatric surgery and develop an academic arm? Because, you know, you do have some academic training. So we embraced a public health worker to work with the pediatric surgeons, and we formed the research arm of the Muhimbili Oxford Training and Research Centre. So we do courses, we do research, but in a collaborative way. And how do we choose our projects? We don't choose the project chooses us. And I'll give you one classical example. So this is a research story from patients. So during a ward round, we were all gathered around in this one ward, nurses, junior doctors, consultants, and we started speaking to the mothers because they were a little chatting among themselves and said, what can we do better? What is troubling you people that we can improve? And the mothers talked about wound infection. They just said, after some time, some of our children start smelling, and it's not pleasant because they get very sick and some of them die. So they gave us the question to look at wound infection. The idea of looking at wound infection came from the mothers. And then there was an auxiliary nurse, and she said, oh, you know, I was working in this community hospital, and whenever a doctor used to come to do the Caesars, we used to give the mothers a bath, and our wound infection rate went down. So an auxiliary nurse gave us a solution. So we had a roundtable conference and ideas were judging out. And as I said, the public health worker who's really sharp at developing projects said, let's do a randomized controlled trial on surgical site infection. So we called it the SOAP study, where the intervention arm was where we gave the mothers soap and water. Cost me about 50 pounds to buy a whole lot of just ordinary soap, not medicated soap, and towels. And then we ran a program of training these mothers how to bathe the children before the surgery, such as if you're doing a laparotomy, you clean the umbilicus and so forth. If you're doing head and neck surgery, you clean behind the ears more carefully than other sides. And the control arm was what surgeons normally did. Either some said, okay, betadine prep before surgery, some said chlorhexidine prep before surgery, some said antibiotics before surgery. So we used that arm. And in 9 months, we had a 80% reduction in surgical site infection, just with soap and water, right? Idea came from the mothers. The problem came from the mothers. The intervention arm came from the auxiliary nurse, and a successful research program because everybody was involved, and it was the need, and it was something that they wanted to do. We also then, further on, we found out that a lot of the families that were coming for their major operations at these tertiary institutions, Tanzania's government gives them insurance for that. So it's 67 USD that they were given. And when we did the study interviewing families, we realized that they need about more than $100 US. So we did the study and we took it to the government, and they upped the insurance to $100 US per patient. So again, just coming from the ground, it's not something that I sat in my office in Oxford and thought up. We also do Rihanna's story. So what you find is that the surgical checklist is, it was introduced and designed by high-income country, and it's used kind of like religion, that everybody does it in a high-income country. It's not very well accepted in the low-income countries. So what we did is, together with the entire theatre team, we designed a booklet where from the time the child leaves the ward, there's a check by the nurse, then the porter does a check, then the porter, the ODP that picks up the patient in theatre does a check, the anaesthetist does their checks, the surgeons do their checks, they write their op notes, the anaesthetist chart, all of that is in one booklet. So we've done this and kind of tried it times. The first time there was only 50% acceptance because some people didn't understand what the booklet was actually going to do. So we reran a training program, and the entire team in Tanzania in this one hospital has accepted it. And we're struggling just to get the government to rubber stamp it, because if we're going to use this concept, we need the government to rubber stamp it. So it's happening. They're not saying no, but they just take time. I also have joined students in low-income country universities or middle-income country universities, and I do joint supervisions with my colleagues there. I've got projects with African universities. I have several MSc students. These are just two examples, several PhD students with universities in Tanzania, universities in Kenya, universities in South Africa. There are lots of topics that you can cover in global surgery. I mean, one of my PhD students is going to look at ear infections in Zimbabwe and see why so many children are becoming deaf because of delayed treatment. So that's a really impactful project. And any of my students who join me, whatever they do, have to be impactful. And then this is their lifelong career to work on that throughout their life so that they can make a relevant change. I think I'd like to just touch on sustainable healthcare. It's all become fashionable again in high-income countries, but in low and middle-income countries, it's always been there. So in Tanzania, in the first hospital that I was collaborating with, they have huge gardens. The hospital is at the foot of Mount Kilimanjaro. So when you walk to work, the mountain is behind, and when you're in the hospital, you can see the mountain. So they have the gardens, and patients and staff work in the gardens, and the gardens grow the food for all the patients. The box that you see next, this is a homemade neonatal incubator. So an incubator costs about 25,000. This is, let me just hold on this. Hello? Yeah, okay, I'm just giving a talk. It's going to end in about 5 minutes. Yeah, it's consented. The patient's consented. I haven't checked if the blood is ready, but the patient's consented. Yeah. If you phone Arindam, he's happy to who with you. And then I'll come down immediately after my talk. Yeah, Arindam now, yeah. Sorry about that. So this is a homemade incubator. So this is a box, and there's a shelf in the middle there. It's Gamgee on top with a premature baby in there to keep them warm. A perspex glass so that they can be seen, but open at this end. A thermometer there to measure the temperature, plugged in. Below there, there's a heater, so they can monitor the temperature and a heater. So one nurse can look after at least 10 incubators, which is the norm there. So they're innovative. Gloves that are used in theater are washed, and then the cleaners use it when they walk around the wards, so they don't have to, so they're recycling gloves. And parents do a lot of the cleaning and the training and wash dishes and look after their children, so infection rates are low. And that's another way of sustainable healthcare. In Bangladesh, what they do is we use stoma bags to cover stomas. In Bangladesh, they use betel leaves. They prevent the skin becoming eroded around the stoma. The bananagram is a very nice concept. So when we do surgeries and before we close the abdomen, close the stomas, we do a contrast to see that there's no blockage or there's no stricture. Because they don't have contrast, they use like a plastic tube that looks like a condom, and bananas are free, so they mash them up and they push them into this tube, and then they squeeze it through the stoma. And if it comes out like a sausage, then they know there's no obstruction. If it comes out like toothpaste, then they know there's a stenosis. And if it doesn't come out at all, then you know there's this obstruction. They also do so neonatal surgery, they can't get anesthetist, and it's very difficult to train nurse anesthetists to do sick neonates. So due to high mortality, they're starting to do the neonates under local anesthesia very successfully. And we in Oxford have started doing neonatal hernias, under 6 months of hernia, under caudal or spinal, which we've been doing for years and years in South Africa. So lots of sustainable stuff that is fashionable now in the high-income countries has been practiced for years in low and middle-income countries. These are all the people that we collaborate with here in Oxford. It's an open door. I meet anybody who wants to work with us. As long as my ethos is carried in the work that they do, it's not about themselves. It's about getting equitable healthcare worldwide. Thank you very much for your attention, and I'm sorry about the interruptions.
Thank you so much, Doctor, for that enlightening presentation. I think that has to be one of the, I'm a global surgery policy and advocacy fellow, and that has to be one of the best lectures I have ever had in my whole life on global surgery. It was very honest, candid, and to the point, and very enlightening. Especially, I also come from an LMIC, so I can relate it on a very intimate, personal level. So if there are any questions, does anyone have any questions for Dr. Lakhoo on this?
You're welcome to contact me if you want to start a project or something. I don't know how to do this, but if you, I can put it in the chat. I can give you my mobile, where's the chat? I can give you my email address and you can contact me on that. It's usually at the, where is it on this one? Sometimes it's at the bottom, sometimes it's at the top. Have you got your chat?
Doctor, you can
Probably let me take over the screen. So
yeah. Yeah, if you take over the screen, I can put it in the chat. Or I can just come out. Yeah.
I couldn't. Give me a second.
Okay, I'll stop sharing.
Yeah.
Oh, stop sharing button.
Doctor, if possible, I had a question from you, a couple of questions, if possible. If you have a moment. The one thing that I wanted to ask you is, right, from what I have seen today, like global health and global surgery has become somewhat of a one of the favorite slides that you have put is about regarding research, publications, and profiteering. So it has become one of the means to get to that end, and it has uh, become quite far away from universal healthcare and global surgery, and from what the initial priority was. And as in the case of everyone, there should be some purpose that makes them wake up in the morning and that makes them tick. And what are their priorities? If the priorities are all wrong, and not wrong in the sense, if it is not the global surgery goals, if in the sense, how would we strike a balance in between that? Because from what I see today, I don't want to name names or anything, but it's become a game of a means to an end that is quite far away from universal healthcare. So
that's exactly what I spoke
yes.
about, to say that
Yes.
the way it's become now fashionable, it's become sexy to have global surgery. But
Yes.
what is global surgery? Global surgery is working together, bringing about equity around the world, so that if you go for a tooth extraction in India or in Africa or in the UK, you get the same treatment, right? You might go under a tree to have your tooth extracted in India, and you have a fancy ward, but the mechanism by which where you give the local anesthetic or the medical treatment, the essence of the treatment is no different, you know. And I think if you are young people like yourself, as I said, you know, if you champion this, if you say this is not global surgery, it's not about getting grants and writing papers and getting promoted. It's about what you need to do there. And, you know, I worked with Tanzania from the year 2000, and only in 2023 did I ever meet up with the ministry, because they were not important to me. My colleagues were important to me. But what we had is, you know, they've got this new concept of the NSOPs. So we had designed the NSOPs for children years ago. We just met up with the government and said, here's it. It's all done. You don't have to do this work. And that NSOP from Tanzania is from the ground. It's what is needed. And it's put together. And look, it's not ideal yet. We haven't reached it. But in Tanzania, the Sustainable Development Goal will be ready by 2028 in Tanzania's children's surgery, because we've been working on it from from the time we met. And you also remember, you're a visitor there initially. People don't trust you, as they shouldn't. They shouldn't trust you till you prove yourself that you are interested and you want to see development, and not about the I. It's not about the I, mine, and me. It's about the we, us, and ours. And just look up literature from LMICs. It's usually grey literature on the Ebola crisis. I mean, the West went out there, the high-income went and made a mess, whereas there was beautiful communities that managed it. Yes, some people died, but the fatality wasn't that high. So the fatality where these tents came up and this banjo and all this razzmatazz with the BBC on one side and CNN on the other side, it actually caused more damage because local people had to clear up after that. And even when you have disasters, right? The disaster management in the first 48 hours is very important. And most of the local people sort that out. So by the time the banjos come from the West to say we're coming to save people, things are already, the immediate stuff is already done. But what you need the local community, the international community for, is to start helping, the backlog in the hospitals. Like, because of the disaster, everybody's working for the tsunami. So in the wards, all the elective procedures are not done. The emergency procedures are becoming kind of later and later, So the international community can help there. They can help provide food. They can help do bandages. But the immediate work is already done by local people. And, people don't understand that. They don't appreciate that. And you just take Syria, right? Syria's health system is run by volunteers called the White Helmets. It's a community. They see a bomb falling somewhere. They rush there. They save their people. They treat them. All these interventions coming from international are not really doing much. They are needed. I'm not saying they're not needed. It's a bit like Gaza. Gaza's medical team are doing immense amount of work because some of my colleagues are going there. But they said they don't need surgeons there. They need the equipment. Like, the biggest thing is burns. So they need burn medicine. So in our department, as consultants, we're collecting funds because we know who to give it to take it out there for the burns management, because that's the biggest calamity in children. Not it, even these targets where kids are getting injured from the war, but more of them are getting injured because there's cooking happening next to the patient in an open area where kids are running around. So the biggest issue is not the artillery. Biggest issue for kids is burns. And how would you know? Is anybody talking about it? Because burns is not sexy. Yeah. So it's up to us now. Slowly, there's no quick fix. But if you just do a little bit, it will change the world. It will. And if everybody thinks like us and does the right ethos, we will see the world changing. I mean, at the moment, the world's leadership is absolutely rotten, right? What can we do? But we do the right thing, because children coming up under us, people that are coming up below us, understand what is values. They don't have to listen to the world leaders who are rubbish at the moment.
Doctor, one more thing, talking about that, a follow-up question is like I personally believe that one of the things to achieve healthcare as in a moment when we can't rely so much on the leadership, as you mentioned, because most of the countries and nations are focusing inwards more than outwards right now. So in this moment, I think one of the most things that we can do, best things we can do that is sustainable is innovation, and something that in LMICs, it's we have to do it. It's do or die. It's not a choice.
Yeah. And, we talk about AI and innovations here.
Yeah.
I mean, I worked in South Africa. We've been innovating from the beginning because we don't have, I'll give you an example. So some babies are born with posterior urethral valves. I don't know if any of you. So what happens is that in the male urethra, there's a valve between the bladder and the urethra. So what happens is that, in part of the urethra, so what happens is urine can't get out. So you get a backwash. So the bladder blows up, the ureters blow up, the kidneys blow up, and then they die from renal failure. So one of the things you have to do is you call a resectoscope. So it's a scope, and then it has a channel with a knife on it. So here we resect it. It's called a resectoscope. So in South Africa, we didn't have a resectoscope. So we took a Fogarty catheter. We put it through the channel, right? Because it would only take a Fogarty catheter. So we created our own resectoscope, and then we took off the tip, the balloon, right? And so the balloon taken off has got a guide wire. And at this end, it's, you can see the wire. So you touch the wire with diathermy, and it burns the valve. And it's controlled because the rest of the tube is covered with plastic. Yeah. So, that's innovation. Like, we do all our neonatal hernias there under local. Yeah. So we give spinals, we give caudals, and we do our hernias. Our tracheoesophageal fistula opening into the chest, we do a spinal, like an epidural that you do in maternity. We put it up, thoracic epidural, and we do them awake under epidurals. So the innovation is there, and there's a big drive in LMIC to innovate and not be high income country dependent, which is really a good drive.
Yeah, I think you have a shortage of time right now.
Yeah, I need to rush to theater now. Yeah.
Thank you, everyone. Thank you, Dr. Lakhoo, especially for this very enlightening. I hope to work together more with you in the future and engage with you in the future more. And it has really been a blessing for all of us to have you talk today. Dr. Preeti,
you can look up our website on the Nuffield Department of Surgery, Oxford Global Surgery, and you'll find us there. But I put my email address there, so at any time, think about what you'd like to do, how you want to engage. I'm very happy to have a chat.
Thank you so much.
And
Thank you, Dr. Lakhoo. I'm confident that all the members, all the audiences today are inspired and looking forward to how they can contribute to global surgery domain. And I'm sure there are a lot of emails that are going to come up to you. So thank you for this amazing session. Dr. Pablo, would you like to say the end note?
Yes, really briefly, if you agree, Dr. Lakhoo, I will share also the recording, or we will share the recording with our members. And once again, thank you for this inaugural meeting from the joint webinars we're doing between the World Medical Association Junior Doctors Network and Incision. It was a pleasure having you here. And thank you, everyone, also for your attention. We'll see you on the next time.
Okay. Take care. Thank you for having me.
Thank you, doctor. Thank you, everyone.
Thank you, everyone.
Thank you so much.
Bye.